Now let's get into the investigations of atrial myxomas. Usually they are identified by echocardiography, but let's go through different methods. On a plain chest x-ray, it is important to know that it may look absolutely normal. If there are any abnormalities, however, they are usually non-specific and include cardiomegaly owing to the left atrial enlargement, intracardiac tumoral calcification, evidence of a mitral valve obstruction, and evidence of an elevated left atrial pressure, such as pulmonary edema. Now coming to ultrasounds, again, echocardiography is a usual method of identifying cardiac myxomas. A hyperechogenic lesion, which is basically tissues that have higher echogenicity, can be seen with a well-defined stalk. This is also great to assess the mobility of tumor, as it often protrudes through valve flaps. In a question, they may ask the best way to investigate an atrial myxoma. For that, you should know that it is the transverse transesophageal echocardiogram diagram, which is diagnostic. The myxoma can also be viewed on a CT, and if the mass is pedunculated, the motion within the heart can be seen, including prolapsing through the mitral valve. Now, moving on to the treatment and prognosis of atrial myxoma. Now, the treatment of the atrial myxoma usually is complete resection, and the recurrence rate is under 5%. And just to really stick in your mind what this looks like, here is an image of a resected jelly-like myxoma. In atypical cases, or those with Carney complex, which is a hereditary condition associated with spotty skin pigmentation, myxomas, and a number of other tumors of the endocrine glands, the recurrence rate is much higher, about 12 to 22%. Now, let's see what a typical scenario in an exam would look like. A 50-year-old female comes to the ER with a history of breathlessness and an episode of syncope over the past day. On history, she admits to having difficulty breathing in the upright position, which is relieved upon lying down flat on her bed. On examination, bluish discoloration and clubbing of the fingernails is noted, and auscultation reveals a mid-diastolic rumble which changes when the patient changes position, and a loud S1 is heard at the cardiac apex. So what is your diagnosis? Now, the biggest giveaways are the loud first heart sound, which is produced by the mitral and tricuspid valves closing. Next, there's platypnea, which is her symptoms being relieved in the supine position, and the mid-diastolic rumble, which is the mimicking of mitral stenosis. And that's all there is from us today. For more videos like these, keep watching sqadia.com.